What is going on, wonderful people? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my neurology playlist. In previous videos, we talked about neuroanatomy, we talked about neurophysiology and the action potential, we talked about neuropharmacology and the antipsychotics, antidepressants, anti-Parkinsonian agents, anti-epileptics, sedatives and hypnotics, and more. Then we talked about diseases such as Duchenne muscular dystrophy and Becker muscular dystrophy. We also talked about Guillain-Barré syndrome in the last video. In today's video, we shall discuss multiple sclerosis, formerly known as disseminated sclerosis. So, you get a sclerosis, you get a sclerosis, you get a sclerosis, and you get a sclerosis. What does the word sclerosis even mean? It means hardening, but in this case, it means infiltration, because multiple sclerosis can infiltrate every single crevice of your central nervous system, be it brain, spinal cord, optic nerve, or the eyes. Click the like button, click the subscribe button, and let's get started. There are two playlists on my channel. One is called Neuroanatomy, which just has the neuroanatomy, and the other is called Neurology, which has everything. It has neuroanatomy, neurophysiology, neuropharmacology, neuropathology, and more. The problems growing of shortcuts and abbreviations have probably wasted far more time than these shortcuts and abbreviations will ever save. Ergo, it's improper to say to your patient, "My dear patient, you have a moderate to severe case of MS," because MS is very vague. It could mean multiple sclerosis, or it could mean mitral stenosis. So get your head out of your sphincter and finish the sentence. How much time do you think you saved by saying MS instead of multiple sclerosis? Not very. In the previous videos, we laid the foundation of neuromuscular diseases, and we said that if I have muscle weakness, it could be because of a problem in the central nervous system, such as the brain or the spinal cord. Or I could have a radiculopathy, which is a pathology in the nerve root as it exits the spinal cord. Or it could be peripheral neuropathy in the peripheral nerve. It could be a problem at the neuromuscular junction between the nerve and the muscle. Could be muscular dystrophy, metabolic myopathy, or congenital myopathy. Today we're talking about multiple sclerosis, which is a problem in the brain and the spinal cord itself. But in the previous video, we talked about Guillain-Barré syndrome, and Guillain-Barré is a radiculoneuropathy, which is a funny way of saying radiculopathy and neuropathy. If you want to download these doozy colorful notes, go to medicosisperfectionalis.com. I help you learn, understand, and pass exams. A pathology in the brain is called encephalopathy. A pathology in the spinal cord is called myelopathy. The word myelo means core. It could refer to your spinal cord because it's in the core of the vertebral column. Or the word myelo could refer to the bone marrow because the bone marrow is in the core of your bone. See, medicine makes so much sense once you understand what the French toast you're talking about. This is radiculopathy, which is a pathology of the radicals. What's that? This is the nerve root as it exits from the spinal cord. Peripheral neuropathy is a pathology in the peripheral nerve. Myopathy is a pathology in the muscle. Encephalopathy, pathology in the brain. But the brain is too big. We have forebrain, midbrain, and hindbrain. Therefore, there is another word, cerebritis, inflammation of the cerebrum only, not the midbrain and not the hindbrain. How about inflammation of the cerebellum? Cerebellitis. How about a collection of pus in the brain? Brain abscess. Inflammation of the brain, encephalitis. And inflammation of the meninges that cover the brain and the spinal cord is called meningitis. If you wish to see more videos like this in the future, please drop a brain emoji in the comments. Do you remember my 10 commandments of neuroanatomy? See my neuroanatomy playlist to learn more. Remember, rule number 1, thou shalt draw the line in the sand between the motor and the sensory. Draw the line in the sand, anterior is motor, posterior is sensory. Motor is efferent, sensory is afferent. Same thing in the spinal cord, you draw the line in the sand, anterior is motor for the most part, posterior is sensory for the most part. This is ventral root, motor, this is dorsal root, sensory. This is one common spinal nerve which is combined, it's mixed, it has sensory and motor. Commandment number 2, thou shalt understand the difference between central nervous system and peripheral nervous system. Central nervous system is made of two things only, brain and spinal cord, and that's it. Peripheral nervous system is made of cranial nerves coming out of the brain and spinal nerves coming out of the spinal cord. All of your 31 pairs of spinal nerves are peripheral nervous system. All of your cranial nerves are peripheral nervous system, except the optic nerve, because the optic nerve is part of the brain, and the eye is part of the brain, because embryologically speaking, the eye was here, and then it bulged out, taking the optic nerve with it. So this is now your eye, this is the optic nerve, this is the brain. All of them are part of the central nervous system. Let me blow your mind. Do you know the meninges that cover the brain? They are continuous with the covering of the optic nerve. So the pia mater, arachnoid mater, dura mater also cover the optic nerve. Now let me knock your socks off. The dura that covers the optic nerve is the same as the sclera that covers the eye. Central nervous system and peripheral nervous system. Central, brain and spinal cord, that's it. Peripheral, cranial nerves except the optic nerve and spinal nerves. What's the name of the disease where we have demyelination of the central nervous system? This is called multiple sclerosis. But what's the name of the disease where we have demyelination of the peripheral nervous system? It's called Guillain-Barré syndrome. See the previous video in this neurology playlist. And since the optic nerve is part of the central nervous system and not part of the peripheral nervous system, therefore multiple sclerosis affects the optic nerve and the retina of the eye, but Guillain-Barré usually does not. So between these two diseases, which one is more likely to have optic neuritis or retrobulbar neuritis and optic atrophy at the end? The answer is multiple sclerosis, because the optic nerve is part of the CNS and not the PNS. But Guillain-Barré, for the most part, does not touch the optic nerve or the retina. Again, it makes sense once you understand what you're talking about. I want you to be a good doctor, not another doofus with a stethoscope. In your spinal cord, the gray matter is on the inside and the white matter is on the outside. However, in the brain, it's the other way around. Gray matter on the outside and white matter is on the inside. The white matter always has myelinated fibers. So the myelinated fibers are on the outside in the spinal cord, but the myelinated fibers are on the inside in cases of the brain. And since multiple sclerosis is demyelination of the CNS, it knocks out the oligodendrocytes, which myelinates the CNS. And when you do this, the white matter is no longer white. The myelinated fibers have lost their myelin. And you will find that the white matter, which is on the inside in the brain, will start to suffer some lesions like this. We call them hyper-intense lesions on MRI, but they have many other names, and there are many sorts of lesions that can happen in the MRI in cases of multiple sclerosis, but make no mistake about it. These lesions are more central than peripheral in the brain, and now you know why. But in the spinal cord, these lesions are more likely to be peripheral than central, because that's where the white matter is. Again, it makes sense. Is multiple sclerosis a motor disease or a sensory disease? The answer is both. It destroys everything. But since it's demyelination of the CNS, when it affects the motor system, it will be upper motor neuron lesion and not lower motor neuron lesion. Therefore, signs of upper motor neuron lesion can be seen, such as hypertonia, hyperreflexia, positive Babinski sign, spastic paresis rather than flaccid paralysis, and no fasciculations. To learn more about the difference between upper motor neuron and lower motor neuron, please refer to my Neuroanatomy playlist. Remember that cranial nerves 1 and 2 come out of the forebrain, 3 and 4 from the midbrain. They are important for the eye movement. But the optic nerve is important for visual sensation. This is sensory, these are motor. 5, 6, 7, 8 from the pons, 9, 10, 11, 12 from the medulla. All of these are peripheral nerves except the optic nerve, which is central. For the most part, multiple sclerosis affects the central nervous system, so it only affects the optic nerve. However, is it possible for it to affect other nerves that are peripheral? Yeah, it is possible. It's just more likely to affect the optic nerve. Next, since it's a problem in the central nervous system, which includes the brain and the spinal cord, parts of me are being lost, including something important called the medial longitudinal fasciculus, which helps with conjugated gaze with your eyes. If I want to look to my right eye will look right, and my left eye will look to the right as well. In order to have this conjugated movement, where both of my eyes agree to move to one direction, you need the medial longitudinal fasciculus. What's the definition of multiple sclerosis? It's a chronic disease, not acute. It can have acute attacks, but it's a chronic disease for the most part. It's predominantly autoimmune. This is the most prevalent theory. Demyelinating disease of the central nervous system. Clinically speaking, the patient has multiple symptoms. Are they sensory or motor? Both sensory and motor symptoms. They are relapsing and remitting. They come and go over time and space. What does that mean? It means that multiple sclerosis first happened to me in year 2001. And then it disappeared and then came back in 2003. And then it disappeared and came back in 2006 or something like this. So this is over time. Relapsing and remitting over time. But what does relapsing and remitting over space means? It means that the first time I had multiple sclerosis, I suffered symptoms in my left foot, and they were only sensory symptoms. Then it disappeared and came back in my left hand. Then it disappeared and came back in my urinary bladder. Then it disappeared and came back in my right eye. Then it disappeared and came back in the left eye, etc. Relapsing and remitting over time and space, sensory and motor. This is MS. So MS is an autoimmune disease and it attacks oligodendrocytes. Therefore, I lose the myelin in the CNS, leading to upper motor neuron lesion, which is motor symptoms, and sensory deficits. Demographics and risk factors. Most patients are diagnosed between age 20 and age 40. It's more common in females than males, and the ratio is about 3 to 1 or 2 to 1. If you live in northern latitudes, you are at higher risk. Northern Europe is higher risk than Southern Europe. North America is higher risk than South America. Vitamin D deficiency is associated with multiple sclerosis, especially with this HLA type, human leukocytic antigen DRB1. And there are other human leukocytic antigens such as HLA-DQA2 and DQB2. To learn more about human leukocytic antigen, please refer to my immunology playlist. Epstein-Barr virus and human herpes virus 8 are associated with multiple sclerosis. Smoking is a risk factor, and surprise, surprise, being born in spring months. I have no idea why. There is a term that's used in French but not in English. It's called forme fruste versus forme plein. What does that mean? Typical symptoms versus atypical symptoms. Common versus uncommon. It's important to remember that patients are different. Some patients with multiple sclerosis have very mild symptoms. Some patients will never have another attack. They get one attack and that's it. Some patients have many lesions on MRI in their brain. However, these lesions do not do anything clinically. Keep in mind that the definition of MS and the criteria needed to diagnose MS have changed over time. So, what used to be called multiple sclerosis in the past might be called something else today, and vice versa. The clinical picture of multiple sclerosis, symptoms and signs. What's the difference between symptoms and signs? Symptoms has the word Y, so you, the patient, will tell me what's up. However, signs has an I, so I, as a doctor, will tell you what's going on by physical exam. Symptoms of multiple sclerosis include scotoma and visual field defects. Why? Because the optic nerve is toast. Decreased visual acuity, decreased color saturation according to the patient. You can verify visual acuity, but it's very hard to verify the patient's perception of color saturation. The patient will say, it seems less bright, the colors are less bright. Some patients report dull pain that gets worse when the eyes are moving. Double vision or diplopia. Why? It could be because of paralysis of the abducens nerve, which is cranial nerve number 6, or it could be because of internuclear ophthalmoplegia, or INO for short. All of these are visual symptoms. We also have sensory symptoms, such as the patient feeling that the limb is tightly wrapped with something. Fatigue and loss of dexterity. Multiple sclerosis should be on the differential diagnosis list for chronic fatigue syndrome. Gait abnormalities, vertigo, tripping and falling, maybe because of foot drop. Lots of urinary symptoms, such as urge incontinence when my bladder is too active, or neurogenic bladder. Overflow incontinence where the bladder is too lazy. Constipation can happen when the intestines are so lazy. Next, something very important called the Uhtoff phenomenon. What's that? Anytime the temperature rises, the patient's symptoms get worse. For example, hot showers, hot baths, or even exercising because it makes my body warmer, so the symptoms get worse. When the patient says this, pay attention. This could be multiple sclerosis. Next, when it comes to signs, optic neuritis is an optic atrophy. You can see this on ophthalmoscope or fundoscope. Horizontal nystagmus, Marcus-Gunn pupil, and Argyll-Robertson pupil. The swinging action and the prostitute's pupil, so to speak. Blindness can happen. Internuclear ophthalmoplegia, usually bilaterally, because of problems in the medial longitudinal fasciculus or MLF. Sensory issues include hypersensation or hyposensation, hyposthesia or hyperesthesia, pins and needles, tingling and numbness, positive Lermite sign. What does that mean? Flex the patient's neck. The patient will feel sharp, electric sensation down the spine. Foot drop is common. Sexual dysfunction can happen because it's upper motor neuron lesion, hyperreflexia, hypertonia, positive Babinski, spastic paresis, gait disturbances, and scanning speech because it can affect the cerebellum. In fact, multiple sclerosis can affect any part of the central nervous system, including cerebrum, cerebellum, brainstem, cranial nerves, spinal nerves, retina, spinal cord. I know that cranial nerves are peripheral nervous system, but hey, multiple sclerosis can affect that as well. To learn more about internuclear ophthalmoplegia and the medial longitudinal fasciculus, I have a separate video on this topic in my Neuroanatomy playlist, where we talk about everything in detail. This video will teach you about the medial longitudinal fasciculus and the paramedian pontine reticular formation. It will teach you about the oculomotor nucleus and the abducens nucleus and how they talk to one another. By the way, you know why we call it internuclear ophthalmoplegia? Because the problem is between two nuclei, nucleus of 3 and nucleus of 6. Unfortunately, many students think that internuclear ophthalmoplegia can only be caused by multiple sclerosis. I have no idea what these students are smoking, because causes of internuclear ophthalmoplegia are many. They include strokes, multiple sclerosis for sure, infections, freaking tertiary syphilis can do it, rheumatoid arthritis, especially with extra-articular manifestations, severe symptoms, and cervical spine subluxation, metabolic disorders, malnutrition, vitamin deficiencies like B6 and B12 deficiencies. Pay attention, multiple sclerosis usually has bilateral internuclear ophthalmoplegia, where the left eye cannot look medially and the right eye cannot look medially. But if it's unilateral internuclear ophthalmoplegia, for example, the left eye cannot look medially, but the right eye is fine. This is unilateral internuclear ophthalmoplegia, and this is probably a stroke that affected just one medial longitudinal fasciculus. Just like Guillain-Barré, multiple sclerosis has clinical variants as well, including relapsing remitting multiple sclerosis, primary progressive multiple sclerosis, secondary progressive multiple sclerosis, Marburg variant, Baloconcentric sclerosis, and shoulder diffuse sclerosis. If you want to learn more, crack a neurology textbook open, guaranteed to lose your mind, no pun intended. How can we diagnose multiple sclerosis? Clinical signs and symptoms using the EDSS score. It's a very elaborate score on many aspects of patient symptoms, and it goes from mild to severe. So for example, if I have a very mild form of multiple sclerosis, I will have 1/10 score. 1 out of 10 means I'll have mild disease. But if my disease is so severe that it killed me, I will score 10 out of 10, and my mother will be so proud because she does not like 9.5. Lumbar puncture, increase protein, increase mononuclear white blood cells such as lymphocytes, macrophages, etc., but not neutrophils, because multiple sclerosis is not an acute disease. It's a chronic disease. IgG could be high in the cerebrospinal fluid and oligoclonal band, and these are very important. Serum, complete blood count, comprehensive metabolic panel, liver function tests, vitamin D and vitamin B12. optical coherence tomography or evoked responses to check for the visual manifestations and the sensory neuro manifestations. Then MRI, we use McDonald criteria. You may go to McDonald's to get some chicken fingers or some butterfingers, but in multiple sclerosis we have Dawson fingers and hyperintense lesions and punctate lesions and enhanced lesions and ovoid lesions. Acute lesions versus chronic lesions and brain atrophy. All of these are some of the MRI findings in cases of multiple sclerosis, but there are more. What should we do an MRI on? Of course, the brain and the spinal cord, because multiple sclerosis affects what? The central nervous system. Management of multiple sclerosis includes non-pharmacological options, including avoiding exposure to heat because of the Uhtoff's phenomena and physical therapy. Acute management includes intravenous methylprednisone, and then you taper the dose. Plasma exchange or plasmapheresis, because we're trying to remove the nasty antibodies from the patient's blood. We give prednisone because it's immunosuppressant, and multiple sclerosis is an immune response. Chronic management of multiple sclerosis includes interferon. Which one? Interferon alpha, beta, or gamma? Interferon beta. Which interferon beta? Beta 1A. Galtiramir, fingolimod, teriflunomide, dimethylfumarate, siponimod. When something ends in mode, it's a modulator. But when something ends in mab, it's a monoclonal antibody. When it has zoo, it is humanized. When it has li, it's related to the immune system, as in autoimmune diseases, which is multiple sclerosis. If you want me to create a detailed video to talk about these treatment options in detail, including their mechanisms and their side effects, let me know in the comments. Now let's summarize multiple sclerosis in 1 minute. The patient's history is 20 to 40 years old patient, usually female, who lives in the north, probably with vitamin D deficiency or decreased exposure to sunlight, which is related to cold northern areas. Symptoms include visual problems, diplopia, muscle weakness, sensory problems, and the Uhtoff's phenomenon. Hot exposure worsens the symptoms. Physical examination, positive Lermite sign, internuclear ophthalmoplegia, upper motor neuron lesion, hypertonia, hyperreflexia, positive Babinski, tingling and numbness, paresthesias. You diagnose it clinically, lumbar puncture and MRI. The treatment is IV methylprednisone or plasma exchange, interferon beta, galtiramir, and fingolimod. You know why we call it fingo? Because it's a sphingosine. And why mode? Because it's a modulator of that sphingosine. Some pearls for the pros that no one will teach you. Did you know that multiple sclerosis can present with petechiae, but Guillain-Barré does not? In fact, few authors argue that this multiple sclerosis could be related to a fat embolism that is subacute and can reach the brain, and they argue that this is the mechanism behind multiple sclerosis. Most authors do not agree with this, but it's a hypothesis. Next, multiple sclerosis can present with white nails. We also see white nails in liver cirrhosis and other medical conditions. Multiple sclerosis can present with Horner syndrome. Multiple sclerosis can present with Marcus-Gunn pupil or with Argyll-Robertson pupil. Argyll-Robertson pupil is classically referred to as prostitute's eye. Why is this? For 2 reasons. Reason number 1, it was first discovered in neurosyphilis, which is a sexually transmitted disease. Reason number 2, just like a prostitute, Argyll-Robertson pupil accommodates but does not react. If you know what I'm saying. What does accommodates mean? The lens becomes spherical for near vision. What does react mean? React means pupillary constriction in response to light. Multiple sclerosis can lead to optic neuritis, which can lead to optic atrophy, which can lead to blindness. Multiple sclerosis can lead to arteriolar constrictions on the retina, which explains the scotoma and the decreased visual acuity. And surprise, surprise, these symptoms can improve if you give your patient vasodilating drugs, because they vasodilate the constricted arteries of the retina. And if damaging the retinal arteries were not enough, multiple sclerosis will also hammer the veins, called venous sheathing. What is this? In the retina, the arteries and the veins cross on one another. And this is the only part in the human body where you find an artery and a vein sharing one tunica adventitia. which is the outer coat of the vessel. Sheathing is when you find changes there on ophthalmoscopy or fundoscopy. Multiple sclerosis can lead to anosmia, which is loss of smell. It can even lead to amenorrhea, loss of menstruation. And let's say that you tested the patient's right eye alone and everything was fine. The right eye could move left and right, up and down. Next, you covered the right eye and started testing the left eye on its own. It could move medially and laterally, up and down, and everything is hunky-dory. Then you ask your patient to open both eyes and started testing both eyes together. Now there is a problem. Oh, what's going on? Both eyes cannot look to the right together, or they cannot look to the left together. In most cases, this is a CNS disease. Do not blame it on a peripheral nerve or on a muscle. Have you watched my previous video on Guillain-Barré syndrome? In that video, I asked you an important question. The deep tendon reflexes are blank in case of Guillain-Barré. Is it A, B, or C for this? Is it A, B, or C for this? A, B, or C for this? A, B, or C for this? Please pause the video and try to answer this yourself. First, in Guillain-Barré, the deep tendon reflexes are usually absent because this is a lower motor neuron lesion. Miller fissure is a variant of Guillain-Barré, so it's the same answer, absent deep tendon reflexes. Myasthenia gravis is neither upper motor neuron lesion nor lower motor neuron lesion, so myasthenia, believe it or not, will have normal deep tendon reflexes. How about botulism? Oh, botulism can definitely affect nerves. And nerves are peripheral, and peripheral is lower motor neurons, and therefore botulism can lead to diminished reflexes. Do you want to learn about strokes? Do you want to learn about myocardial infarction, cardiac arrhythmias, acute limb ischemia, acute respiratory distress syndrome, drowning, all the toxidromes that you can imagine? Download my emergency medicine high-yields course at medicosisperfectionalis.com. It comes with videos, notes, and cases. Do you want to learn about neurosurgery and cardiothoracic surgery and pediatric surgery and trauma surgery? Download my surgery high-yields course at medicosisperfectionalis.com. To learn about neuropharmacology, the anti-epileptics, the antidepressants, the antipsychotics, the anti-Parkinsonian medications, the anesthetics, the sedatives, the hypnotics, the stimulants, and the opioids, download my neuropharmacology course at medicosisperfectionalis.com. If you found these videos to be helpful, please consider supporting my channel by buying me a coffee. Go to buymeacoffee.com/medicosis. There are more than 600 premium videos available on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.